While scientific ideas are discussed in this program, it is primarily intended for the layperson. It is anticipated that the viewer likely will be a fibromyalgia patient or family member, and so the language is deliberately non-technical. It is hoped that this program will serve as a bridge for patients, providing easier access to the growing body of knowledge about fibromyalgia syndrome. The information provided in this program is not intended to replace the advice of a doctor or other healthcare provider, but is rather intended to help you make better healthcare decisions and take greater responsibility for your own health. You should not use this information to diagnose or develop a treatment plan without consulting a qualified healthcare provider. The study of fibromyalgia has brought tremendous advances over the last 15 years. New sources of information demand that we periodically review and reevaluate what we know about fibromyalgia. This presentation takes a look at some of the most significant theories about the pathology, diagnosis, and treatment of fibromyalgia syndrome. The symptoms of fibromyalgia have been documented for at least 2 centuries and likely have been known for much longer. Called muscular rheumatism in the 19th century, it was described as a condition causing fatigue, aches, pains, stiffness, and insomnia. Sir William Gowers is credited with coining the term fibrositis in 1904, and soon after references to fibrositis syndrome appeared in the literature. The modern study of fibromyalgia began in 1972, when the description of widespread pain and tender points first appeared in the literature. As knowledge about the condition grew, it became clear that inflammation was not a part of the pathology, and the itis ending of fibrositis, which indicates inflammation, was dropped. In 1976, the term fibromyalgia was introduced to reflect this new understanding of the pathology. But it wasn't until 1990 that formal criteria for the diagnosis of fibromyalgia syndrome were established. Though fibromyalgia syndrome may express itself in many different forms, it is at heart a disorder caused by over-amplification of pain signals. Sensations that seem benign to a healthy individual are perceived as painful to a fibromyalgia patient. And because fibromyalgia is a central nervous system disorder, it has the potential to affect diverse systems throughout the body. Understanding this concept is the key to understanding fibromyalgia. Of course, chronic pain is quite prevalent even in otherwise healthy individuals. 20 to 30% of the general population suffer from chronic regional pain at any given time, while 10 to 20% suffer from chronic widespread pain. It is estimated that 3 to 5% of the general population meet the diagnostic criteria for fibromyalgia syndrome at any given time. In 1990, the American College of Rheumatology defined these criteria for the first time. In order to meet the diagnostic standards for fibromyalgia syndrome, patients should have widespread pain that persists for at least 3 months. To be considered widespread, pain must occur in both sides of the body and both above and below the waist. There must also be an axial component to the pain, that is, pain occurring centrally along the trunk or spine. Additionally, pain must be noted in 11 of 18 predefined tender points. While these are the standards, many patients are diagnosed and treated for fibromyalgia without having strictly met all the criteria, and alternative methods of diagnosis have been introduced. These alternative methods usually incorporate some form of diagnostic interview that focuses on the functional impacts of fibromyalgia instead of using the tender points examination. In addition to the pain caused by sensory amplification, fibromyalgia can affect seemingly unrelated areas of the body, and patients usually present with multiple symptoms. Some of these symptoms, like headache, may be a direct result of the fibromyalgia patient's altered pain perception, while other symptoms, like mood disorders, seem to be chromosomally linked with fibromyalgia. This amorphous character can make diagnosing and treating fibromyalgia difficult. The usual diagnostic procedure follows the American College of Rheumatology's criteria, with the added step of ruling out differential diagnoses. This is important because what at first may appear to be fibromyalgia syndrome sometimes turns out to be a completely unrelated condition. Even when meeting the ACR's diagnostic criteria for fibromyalgia, these conditions should be ruled out before proceeding. Some practitioners, primarily mental health professionals, prefer to skip the Tender Points test altogether, replacing it instead with a diagnostic interview. The rest of the algorithm remains unchanged. Because fibromyalgia can affect so many areas of the body, it is often diagnosed concurrently with other conditions. It is helpful to think of fibromyalgia as having two components: the primary pain amplification disorder and the secondary functional manifestations. Therapies are usually directed at both of these components. The conditions commonly associated with fibromyalgia are actually widely dispersed throughout the general population, but the heightened sensitivity to pain can make what might be an annoyance to an otherwise healthy individual unbearable to a fibromyalgia patient, and conditions that might not even be treated in a healthy individual might require aggressive treatment with fibromyalgia. Sleep disturbances are extremely common in fibromyalgia patients. Many times, patients aren't able to fully recover after falling behind on sleep, and the cumulative effect over long periods can leave fibromyalgia patients exhausted and cognitively impaired. It is a continuing theme in the study of fibromyalgia that the effects of one symptom often exacerbate other symptoms, many times in a vicious cycle of pain and fatigue. Some impairment of cognitive function is typical in fibromyalgia. This may be due in part to sleep deprivation, but some small studies have indicated that the brains of fibromyalgia patients undergo morphological changes, including the loss of gray matter volume. These small but intriguing studies indicate that the brains of fibromyalgia patients age at an accelerated rate, especially in patients with a long-standing diagnosis of fibromyalgia. Irritable bowel syndrome is also quite common in fibromyalgia, occurring in as high as 70% of patients. Some studies have shown bacterial overgrowth in the small intestines to be the source of the problem, indicating antibiotics may be of at least temporary benefit. Surveys indicate that restless leg syndrome occurs in more than 30% of fibromyalgia patients, though exactly how they are related is unknown. Symptoms of restless leg syndrome are usually worse during periods of inactivity, especially at night. The full impact of anxiety-related disorders on the health of fibromyalgia patients has only recently begun to be appreciated. As with most mood disorders, significant comorbidity with fibromyalgia exists. Fibromyalgia and mood disorders, such as depression, are often comorbid. At the time of initial diagnosis, as many as half of fibromyalgia patients are also diagnosed with clinical depression. Depression associated with fibromyalgia does not appear to be simply an alteration of affect due to persistent pain, but rather seems to be genetically linked to fibromyalgia. Mood disorders like depression and fibromyalgia tend to cluster along familial lines, and in families where one condition is found, the other is 8 times as likely to be found. Several mechanisms for the comorbidity of fibromyalgia and depression have been proposed and are fertile areas for current research. Many of these theories indicate mood disorders and fibromyalgia are genetically linked. It is thought that fibromyalgia is caused by the expression of a combination of genes rather than by a single gene, and there is likely more than one combination of genes that can code for fibromyalgia. This means that the root cause of fibromyalgia may not be the same for everyone, and in the future, therapy likely will be customized for the individual. Specific genes potentially involved in the pathogenesis of fibromyalgia have been identified by researchers and are currently under study. This area of research offers great promise for the future diagnosis and treatment of fibromyalgia. While the potential to develop fibromyalgia appears to be genetically mediated, a trigger is usually required to activate the syndrome. Environmental triggers take many forms, but stress and traumatic experience are underlying commonalities.